pleasure to introduce Dr. Lauren Krupp, and she's going to deliver the Lancet Lecture.
It's a pleasure to be here with you all today. And I'm going to try to cover 3 areas: cognitive issues, fatigue, and mood, and how we try to manage them in people with MS. And my PowerPoint is just going to cover the cognitive aspects, but I can share with you after the conference PowerPoints on the fatigue and mood. And the first thing that I wanted, these are my disclosures, is that when we talk about cognitive problems, you know, we're really talking about not so much what the person complains of, but really cognitive impairment refers to a performance deficit relative to a normative comparison on very specific tests of neuropsychological function. So it's actually, of course, a big challenge. If you can't get testing done, how do you know if somebody's cognitively impaired? And there's no great answer to that. One approach is to use screening measures. So, you know, the one measure that's most sensitive is this single digit modality test. And we can often administer that, you know, in the outpatient setting. The training for it is not very involved, and it's a quick test. It takes 90 seconds for the person to perform it, maybe a minute or 2 to explain it, and 30 to 60 seconds to score it. So it's just a screen, it's just an indicator. And the reason why testing becomes important is that when people complain that they can't remember, they're forgetting words, you know, it's very mood dependent. So I can't remember where I parked my car. Oh my God, I'm dementing. I better see my neurology colleagues. You know, what's happening to me? I'm in big trouble. Or I could say, I can't remember where I parked my car. This happens to me from time to time. You know, I'm an absent-minded professor, and I have a lot more important things to think about than where I parked my car. And I don't plan to mention this to anybody. So I think the complaint is not correlated with the performance. It's correlated with mood. That doesn't mean to say that people with definite cognitive impairment might not complain of it. But more often than not, when people are very worried about their recall and not remembering people's names in the course of a conversation, we call it the worried well. Because if you think about it, when you see a person with Alzheimer's disease, and granted, people with MS don't have that severity of impairment, but nonetheless, they often don't know why they're seeing the doctor. So very important to sort of know when you're dealing with cognitive impairment. And the most important resource is really the friends, the spouse, the partner, the wife, the husband, the children, because if they're noticing a problem with the person with MS, that's a lot more reliable indicator that you're dealing with an issue. So what are we going to do about it? Well, you know, in a global level, big picture, it makes sense to use disease-modifying therapy to preserve cognition. Why? Because the accumulation of lesions, and more significantly, the progression of brain volume loss isn't good for us in general. Now, there are people with tremendous cognitive reserve and brain reserve for whom this does not take such a great toll. And then there's other individuals who are not so lucky. And some of them may be highly educated and whatnot, but nonetheless, the progression of thalamic volume loss, cortical gray matter volume loss, white matter volume decline, but really it's the gray matter that probably is most critical, leads to declines. So disease-modifying therapies have been shown in meta-analyses to have a favorable effect on cognitive outcomes relative to no disease-modifying therapies. Now, that doesn't mean if somebody has a cognitive problem, you give them a disease-modifying therapy and their cognitive problem is going to go away. Absolutely not. But the idea is that you're, because of practice effects and other things, when we repeat testing in the context of having started a treatment and then repeating the assessment, a year later, we tend to see improvement. And that tends to be practice effects. But we see more improvement in general in patients on disease-modifying therapy versus not on disease-modifying therapy. So what about high efficacy therapy versus low efficacy therapy? Well, so far that has not really been convincingly demonstrated, with the exception that recently with the S1P receptor inhibitors, there is a trial that did show an improvement on the SDMT relative to the comparator, which was a different, less effective oral DMT. And we also know that, again, relative to placebo, there's some benefit. So on the other hand, there is at least one study showing that if you compare high efficacy medications to moderate efficacy medication, there is a relative preservation of brain volume regions, specific brain volume regions with the high efficacy therapy. And so we could extrapolate to imagine that preserving gray matter volume, preserving thalamic volume more efficiently should in the long run result in better preserved cognition. And I think, again, one of the challenges with the experimental evidence for this is that cognitive changes take time to see. Most people with relapsing remitting MS on a cognitive assessment don't change that much in the short term. Now, of course, people with progressive MS who have cognitive problems and cognitive impairments change more, and their change is more apparent. I don't think it's a matter of you're going along with relapsing remitting MS, you're stable, and then you fall off a cliff. I think there's change that's happening that's subtle that we can't really detect so well with our current assessment tools. And then there's a threshold that's met, and then the cognitive dysfunction becomes more apparent. So, that's sort of the pharmacologic side of things. From my point of view, high efficacy DMTs make more sense in terms of preserving cognition, but it may be more critical for some people than others. So may not be as critical for someone with no brain volume loss, small lesion burden. Not that the lesions correlate well with cognitive loss. They, as mentioned by a prior speaker, they don't. But lesion accumulation is probably better correlated with brain volume loss, which in turn correlates with cognitive performance. The symptomatic therapies, meaning the kinds of medicines that are used for symptomatic management for Alzheimer's disease, don't really work. And I say that having published a study, I think, 18 years ago, well, maybe not 18 years ago, a long time ago, 8 years ago, I guess, showing that a cholinesterase inhibitor was effective on a verbal memory measure in people with MS compared to a placebo. But what happened is when we tried to expand on that study and make it a multi-center study with a larger sample, we couldn't replicate the findings. And in fact, other investigators using different cholinesterase inhibitors similarly have more or less shown no real benefit. So there's a Cochrane review that sort of comes to the conclusion that pharmacologic symptomatic medicines are not very helpful in preserving cognitive function in people with MS. Cognitive rehab, on the other hand, is an important thing to do. Managing the things that can make cognitive performance worse is important too. So poor sleep, if somebody has sleep apnea and they're hypoxic, that's not good for their cognitive thinking. If somebody's getting disrupted sleep all night because they're going to the bathroom all the time, that's not helpful. The specific cognitive rehab approaches, this is difficult because usually somebody who wants to do cognitive rehab is going to want neuropsych testing, and we can't always get neuropsych testing. The occupational therapists in general are the group that have more familiarity with helping people with cognitive challenges. And what I think might be an important opportunity for the future is coupling cognitive rehab with neuromodulation. So this is now in the research realm, not so much in the daily practical, I can get this from my patient. But I do believe that in the future, the option for neuromodulation will continue to grow and be possible. And by neuromodulation, there's different formats. There's TMS, which is transmagnetic stimulation. There's TDCS, which is transcortical direct stimulation using low pulses of electric current. And what we found is that when TDCS is coupled with cognitive training, the outcomes are better than if you do the cognitive training alone. So we did a sham versus active TDCS coupled with cognitive rehab. Now, what if you don't have cognitive rehab and you don't have neuromodulation? What else can you do? So there are different online computer-based programs, not particularly expensive, and that can be tried. So the concept here is that you want to have people do things, and if they do them well, it gets harder. So it's a self-modulated kinds of activity. And one example of that is called Brain HQ. And this is a software that is downloadable on a phone, on a computer. And it's like a computer game in the sense that the better you do, the harder it gets. And it seems that's the key. We actually did a study comparing, this program is made by Posit Neuroscience, and we compared their software program to a program where people on the computer did crossword puzzles and other mind-demanding or brain-demanding tasks, but they didn't get harder as you did it. So, and the Brain HQ proved superior, and our conclusion was it was that taste, individualized aspect that really made the difference. Well, what else can you do? So what about diet? We hear a lot about the need to address questions related to diet, because patients are constantly wondering what they should be eating and how they and whether it will be beneficial for their MS. So there isn't really much that I'm aware of that looks at diet and cognitive performance in MS. But in Alzheimer's disease, there is a diet called the Mind diet. And it's a diet that is sort of similar to what you would imagine, which is, low saturated fats, some fruits and vegetables, things like berries and nuts, and, avoiding fried foods. And what was shown with this Mind diet in a bunch of people who were elderly is that that group on the diet who were most adherent were less likely to develop Alzheimer's disease over the follow-up period. So I try to encourage that diet to people with MS. Exercise is incredibly important to the extent that people can do it. It just makes sense that getting increased blood flow to your organs, including your brain, is going to be good. It enhances quality of life. I recommend, both a combination of resistance and aerobic type exercise. The data is supportive. Would I say is it fantastic? No, but it's supportive and it's not going to make things worse. This is just the meta-analysis showing the different effects of DMTs on different neuropsych outcomes. And this is just showing that because there's not that much data out there with neuropsych, and there is data showing that DMTs have a favorable effect on preserving brain volume, it makes sense to advocate for disease-modifying therapies when trying to preserve cognition. And then these are the different studies showing that, in this case, ozanimod versus interferon beta 1A intramuscular had a better effect on cognition. So the different rehabilitative approaches, the story technique, mental visual imagery, self-generated learning, these are all that have been shown to be helpful. And there are also restorative programs. The Brain HQ I mentioned is mentioned here. Rehab is another computer-based program that has been beneficial. And we, as I said, found that there was benefit with the Brain HQ program on using with the PACEAT and trail making tests and a visual memory test and attention relative to the comparison. And then this is coupling that with neuromodulation. So I want to just move on to the other issues, which are fatigue and mood. So fatigue is a very complex entity in MS. The challenge with fatigue is that it's so multifactorial. And I think the other challenge with fatigue is that we think we know what fatigue is. All of us have felt tired at times. And so how do we understand the fatigue of people with MS? So the first thing I think is education, because there are people with MS and their families who think that the person isn't doing something because they're lazy. And I think that what we have to explain is that they're not lazy. The fatigue in MS is different than what we experience among those who don't have MS. It interferes in daily living. It prevents people from meeting their responsibilities that they define as being their responsibility. And, the analogy is that it's like you have a gas tank that's half full, and you can't do all that you would normally think you could do. So that's to be distinguished from fatigability, which is really a performance decrement, meaning that your performance declines over a fixed period of time. And that's could be on a physical measure or a cognitive measure. But that's really to be distinguished from the self-reported experience of being tired or exhausted or no energy. And, you sort of help people realize that we're not talking about limb weakness. We're not talking about depression or mood. We're talking about a sense of exhaustion. And it's present in all forms of MS. Some people struggle with this in the relapse remitting phase. Others have it throughout their course, and it worsens with time in some cases, or people with progressive disease. And it can be, frustratingly difficult to manage. So how to treat it? Well, I think the first thing is to sort of, one, educate, two, realize that in some people, fatigue is associated with a feeling of being out of control. You want to do this, you can't do it, you don't know why, and it becomes very challenging. So trying to help the person have a sense of control is critical. And because most people have more fatigue in the late in the day, you can explain to individuals that plan your activities, the ones that are most demanding, to be in the morning when your energy level is best or highest. For the mom who is rushing out to work in the morning and preparing breakfast for her children and taking a shower to get ready and doing all these things and really overwhelmed. And by the time she's out the door, she's exhausted. One approach is to say, well, take the shower the night before. Maybe your partner or husband or the children themselves can get the breakfast ready the night before, so it's easier in the morning, and make sure that, the things that are most critical you can do, but you're not piling it all in at once. The other, this is basically comes under the category of energy conservation. And that's a very effective strategy. In addition, there's been some tremendous, I was interested in fatigue many decades ago, because my mentor said, I meet with patients, and in those days we had index cards, and he had the different MS symptoms on index cards, and included was the fatigue. And he said, they always pick the fatigue card. So it's really common. It's the most common MS symptom, which is sort of amazing when you think about all the symptoms that occur in MS. And for many, it's among the most disabling, which is also kind of striking. So when I noticed some years ago that there was some benefit on fatigue and mindfulness, I really paid attention. And I think things like mindfulness, yoga, meditation are very, very important in terms of helping people manage their fatigue. Now, not everybody's open to doing that kind of thing. Sometimes you might want to recommend yoga. Another big element that's useful for fatigue management is exercise. That being said, there is an important caveat, which is if you have a very depressed individual who's also very fatigued, who has MS, my experience is you're not going to get any headway with the fatigue unless you deal with the depression first. So while certainly not all people who have MS and who struggle with fatigue are depressed, there is a subgroup who are. And for that group, you have to manage the depression. Another way of thinking about fatigue is that it's a low affect, a low positive affect. Now we think of affect as mood, but affect can be divided into negative affect, which is sort of feelings of sadness, lack of self-worth, negative mood. And we can think of positive affect, which is not necessarily the opposite of negative mood. Positive affect is more inquisitiveness, reaching out, engagement, and that's sort of what's down. So it's low positive affect that seems to correspond to fatigue. And what causes it? Well, as I say, it's many factors. We know that back in the days when interferon beta 1A IM was commonly used, that was a weekly injection. Of the day after the shot, people would commonly have tremendous flu-like symptoms and fatigue. And so we know that there's a cytokine contribution, or cytokines in plural, associated with MS that are contributing to the fatigue. And so I think there are real immune mechanisms that underlie fatigue, but certainly not only that. Being deconditioned, some people have suggested that there may be some changes in functional MRI and oxygen uptake and utilization in the brain that have a role in fatigue. And way back when, before we had PET and functional MRI, there was the recognition that people whose MS was affecting their brain more than their spinal cord, one, were more likely to have mood issues, and maybe are a little bit more vulnerable to fatigue. That being said, there's certainly a problem with motor function that's relevant to fatigue, because you can get a lot of fatigability, motor fatigability, just struggling to ambulate when you have weak legs and you need a cane, and traversing a room is a big challenge that it wouldn't be for someone else. But that fatigue is partly that, but it's also more than that. Once again, we don't have a much benefit here from pharmacologic interventions. So this too was interesting, because there had been some early work suggesting that amantadine might be helpful for fatigue. And there's also been suggestions that CNS stimulants, as well as medications like modafinil, could be beneficial. So this was really put to the test last year in a publication in Lancet Neurology, showing that amantadine versus methylphenidate versus modafinil versus placebo in a randomized trial, basically there was no difference in the active medication groups compared to the placebo group. There were more side effects with the medication group. The exception, not surprising, is that self-reported sleepiness, which is different than fatigue. Excessive sleepiness is a different phenomenon than fatigue. That did respond to the modafinil a little bit. So the problem here is that there's a big placebo response. I mean, everybody improved, and these medicines were no more potent than placebo, but we can't prescribe placebo. So it's difficult. So there are some patients who are wedded to their amantadine or their modafinil and really don't want to come off. And, you know, it can be difficult. I do not think CNS stimulants such as Adderall or methylphenidate are appropriate in the management of MS. These agents can be addicting. And I think that in general, non-pharmacologic approaches have, you know, a much better yield. And then the last thing I'll wrap up with is mood. And that's basically that both depression, anxiety, and other mood disorders are very, very frequent in people with MS, and higher than what we see in the general population. And, you know, there has to be a real sensitivity and look out for this. And we have to realize that therapy is, you know, really critically important. And in some cases, medication is necessary as well. So that's sort of all I wanted to say. I want to thank everyone for their attention, and happy to take any questions that might be brewing.